Yeah. Good evening, respected professor and my dear students. I welcome you all to this session on DNB Academics Online by RISA. Today we have three important theory questions to be answered. One is by Dr. Prateek Shukla from Guwahati, NF Railway. Another one from Dr. Jayabharti and Dr. Venkat Rao, both from Railway Hospital, Perambur. Without wasting much of your time, over to Dr. Prateek Shukla to go ahead with hypertensive disorders of pregnancy. Thank you.
Good evening, sir. Good evening, sir. Thank you for this opportunity, sir. So my topic is hypertensive disorder of pregnancy. Hypertension is the most common medical disorder of pregnancy, and it affects nearly 6 to 10% population of all the pregnant women. Now, classification of hypertensive disorder is according to ACOG classification of 2013, and it is classified as gestational hypertension, preeclampsia. Preeclampsia can be further classified as preeclampsia without severe feature, preeclampsia with severe feature. Third is eclampsia, fourth is chronic hypertension, fifth is chronic hypertension with superadded preeclampsia. So now what is hypertension? Hypertension is blood pressure more than 140 by 90 mmHg measured two times with at least 6 hours apart. Gestational hypertension is elevated blood pressure after 20 weeks of gestation without proteinuria in absence of chronic hypertension or systemic manifestation of preeclampsia that resolves by 12 weeks of postpartum period. Gestational hypertension is most commonly seen after 37 weeks of gestation. Preeclampsia. Preeclampsia is new onset of hypertension and proteinuria after 20 weeks of gestation. Preeclampsia diagnosis is also considered in absence of proteinuria when there are symptoms of end organ involvement like persistent epigastric or right upper quadrant pain, persistent cerebral symptoms, fetal growth restriction, thrombocytopenia, elevated liver enzymes, HELLP syndrome. HELLP syndrome is considered to be a variant of severe preeclampsia. Eclampsia, a new onset of seizure or unexplained coma during pregnancy or in postpartum periods in women with signs and symptoms of preeclampsia with no any previous history of neurological disorder. Chronic hypertension. Chronic hypertension is said when systolic BP is more than or equal to 140 mmHg or diastolic BP is more than or equal to 90 mmHg, presenting before pregnancy or before 20 weeks of pregnancy, or it is also defined as elevated BP that fails to resolve after 12 weeks of delivery. Chronic hypertension with superimposed preeclampsia. Preeclampsia in women with chronic hypertension before pregnancy is generally a new onset proteinuria or sudden increase in the proteinuria which was previously there, or sudden increase in blood pressure, or both of them. So now coming on to preeclampsia. Preeclampsia is divided into two classes based on severity and based on onset of time. Based on severity, preeclampsia without severe feature and preeclampsia with severe feature. Based on onset of time is early onset preeclampsia and late onset preeclampsia. Early onset preeclampsia occurs before 34 weeks of gestation and it is less common, but it's more severe. Late onset preeclampsia occurs after 34 weeks of gestation and more commonly seen. So now coming on to risk factors for development of preeclampsia, it can be divided as demographic factors, which includes advanced maternal age, that is more than 35 years, teenage pregnancy, black race, or Hispanic ethnicity. Genetic factors, which include previous history of preeclampsia, family history of preeclampsia, history of abruption, history of fetal growth restriction, fetal death, partners who have fathered preeclampsia pregnancy with another woman. Medical condition including obesity, chronic hypertension, diabetes mellitus, CKD, APLA, or SLEs. Obstetric conditions like multiple gestation and hydrated form. Behavioral factor like cigarette smoking is considered to be protective of preeclampsia. Exercise during pregnancy is also considered to be protective of preeclampsia. Now coming on pathogenesis of preeclampsia, exact pathogenesis is not very clear, but some accepted hypotheses are: first, failure of cytotrophoblast to invade the decidual and myometrial spiral arterioles. Thus, there is no remodeling of these vascular smooth muscle. Remodeling of spiral arterioles is seen in normal pregnancy, which makes it non-responsive to vasoactive stimuli, thus maintaining the uteroplacental flow without any hindrance. Second hypothesis is superficial presentation or abnormal presentation. Third is aberrant hemostatic activation. Fourth is autoantibody of angiotensin type 1 receptor. Fifth is reactive oxygen species generation. Sixth is increased production of soluble FMS like tyrosine kinase 1, that is SFLT1, or soluble endoclines, that is SENG, leading to endothelial dysfunction in the maternal vessel. Now, diagnostic criteria for preeclampsia without severe feature are BP more than 140 by 90 of mg, proteinuria more than 300 mg per 24-hour urine, or protein creatinine ratio more than 0.3, or +1 more than +1 on urine dipstick. Diagnostic criteria for severe preeclampsia is BP more than 160 by 110 mmHg, thrombocytopenia, serum creatinine more than 1.1 mg per deciliter or more than 2 times the baseline, signs and symptoms of pulmonary edema, new onset cerebral or visual disturbance, impaired liver function. Moving on to clinical features of preeclampsia, that are CNS. I will be going system wise, sir. So CNS, severe headache will be there, hyper excitability or hyperreflexia, or coma. Patient might be in coma. Visual disturbances like scotoma, amaurosis, and blurred vision. Hyperperfusion of the brain may lead to vasogenic edema, and also there can be a failure of autoregulation of posterior circulation leading to PRES, that is posterior reversible leukoencephalopathy. In CVS, preeclampsia causes increase in vascular tone and increase in sensitivity to vasoconstrictor and circulating catecholamines. Thus, and also severe preeclampsia is a hyperdynamic state. Therefore, complication related to hyperdynamic state can also be seen. In third is pulmonary edema can be seen in is seen more commonly in multigravida patient with chronic hypertension with superimposed preeclampsia, and less commonly seen in young and healthy participants. Hematological complication like thrombocytopenia is the most common one. DIC can also be seen in cases of severe liver involvement or in cases of IUD, placental abruption, or in PPH. Hepatic signs and symptoms are right upper quadrant pain or epigastric pain, which is suggestive of severe preeclampsia. Other hepatic damages ranges from mild hepatocellular necrosis to HELP syndrome, and it may or may not be associated with subcapsular bleeding. Renal involvement when seen is seen with persistent proteinuria and hyperuricemia. HELP syndrome, that is characterized by hemolysis, elevated liver enzyme, and low platelet count, and is considered to be a variant of severe preeclampsia. But this variant as such is a controversial thing because substantial fraction of participants with HELP might not have hypertension or proteinuria. So hemolysis is defined as microangiopathic hemolytic anemia and is considered to be the classical hallmark of HELP, and peripheral blood smear is suggestive of cystiocyte, Burr cells, or acanthocytes. Elevated liver enzyme is increased AST more than 70 international unit, increased LDH more than 600 international unit, or increased serum bilirubin more than 1.2 mg per dl. Thrombocytopenia is defined as platelet count less than 1 lakh per mm cube cell. Now, coming on to management of preeclampsia, it can be divided into obstetric management and anesthetic management. So, obstetric management generally focuses on decision regarding timing and route of delivery, fetal and maternal surveillance, treatment of hypertension, and seizure prophylaxis. So, delivery is the only cure of preeclampsia. As we all know, delivery is the only cure of preeclampsia. Therefore, if pregnancy is more than 37 weeks with gestation, 37 weeks gestation, then patient should be delivered. If delivery is recommended for participant with preeclampsia with severe feature at 34 weeks of gestation, with delay of delivery for 24 to 48 hours for administration. At this time period is required for administration of corticosteroid to facilitate the fetal lung maturity. If delivery is expedited regardless of corticosteroid for patient with eclampsia, with pulmonary edema, patient with DIC, abruption, abnormal fetal surveillance, or non-viable fetus, or IUD. So treatment of hypertension in preeclampsia or eclampsia, drugs used are labetalol in doses of 20 mg IV can be followed up by up till 40 to 80 mg every 10 minutes, up till maximum dose of 220 mg, sir. Hydralazine is given as 5 mg IV every 20 minutes, maximum dose is 20 mg, sir. Nifedipine is given sublingually only and only if IV access is very difficult and it taking time and we need to control the hypertension. Dose is 10 mg per orally every 20 minutes up till maximum dose of 50 mg. Nicardipine is used in cases of refractory hypertension with initial infusion doses of 5 mg per hour, which can be increased by 2.5 mg per hour uh, to maximum of 5 mg, sir. 15 mg per hour to maximum of 15 mg per hour dose. Seizure prophylaxis is by, there are many regimes which are followed. Most commonly used is split chart regime, which causes in which loading dose of max self is given of 4 mg, which is administered over 3 to 5 minutes, followed by 5 mg IM in each buttocks. Maintenance dose is 5 mg deep in each buttock. Alternate, we do that in alternate buttocks now. Other very frequent regime which we follow is Zuspan regime. In that 4 mg IV, 20% in 100 ml fluid is given over 15 to 20 minutes. And maintenance dose is 1 mg, 1 gram per hour in 100 ml of IV fluid. Third is the third very famous seizure prophylaxis regime is CBI regime, in which 6 mg IV magnesium sulfate is given over 20 minutes and maintenance dose is 2 grams IV infusion. Now anesthetic management is focused on ARV management, maternal hemodynamics, coagulation status and fluid balance. So in airway, we anticipate that generalized edema will be present. Therefore, we anticipate and follow all protocols for difficult airways. Hemodynamic monitors, generally NIBP might suffice, but IABP catheterization is considered in cases of severe preeclampsia or poorly controlled hypertension, or when we require regular ABG monitoring. Neuraxial anesthesia for neuraxial analgesia for labor and delivery is considered, and it has major advantages of as such because it controls the hypertension and it avoids the need for going into ARV management. So before giving neuraxial analgesia, 4 considerations should be always looked for. First is assessment of coagulation profile with platelet count trend. Second is IV hydration before local anesthetic administration. Third is treatment of hypotension, which may be a sudden hypotension after giving the drug. And fourth is use of epinephrine containing. We should not use epinephrine containing local anesthetic. So moving on to IV hydration, crystalloids are preferred over. It can be preceded before neuraxial block to ameliorate the effect of hypotension. Preloading or co-loading to decrease the hypotension can be done. And treatment of hypotension is small doses of phenylephrine or ephedrine, in which phenylephrine is more preferred than ephedrine. Now, if anesthesia for C-section, so 3 considerations for inpatient of preeclampsia undergoing C-section is first, choice of anesthetic technique. Second, technique or induction of GA. Third, interaction of magnesium sulfate with NMDA. In all the cases, we should consider all the ASA monitors with large bore IV access. So in neuraxial, if we are giving neuraxial anesthesia for CS, previous consideration should be kept in mind. Less dose of hyperbaric bupivacaine is to be used. Hypotension to be managed by co-loading and small bolus doses of phenylephrine, that is 50 mics per kg. 50 mics bolus. While we are giving GA, which is less desirable than neuraxial blockade, since risk of intracranial hemorrhage is there due to response of tracheal intubation or extubation, but it is done when platelet count falls below drastically or below 20,000 or a severe fall of trend is seen. GA is also preferred in cases of abruption, DIC or IUD. During GA, airway consideration can be seen as difficult airway card should be prepared before proceeding. Endotracheal tube of various size means small size should be kept ready along with LMAs. Supraglottic devices can be used. Hypertensive response to laryngoscopy to be treated with labetalol, esmolol, or remifentanil. So effect of Maxell. Maxell should be continued throughout the surgery to minimize the risk of eclampsia. If NMDA is used, then its dose should be very small because we are giving magnesium sulfate, which prolongs the dose of in NDMA. And for reversal, sugammadex should be used. So technique in the GA which we are giving can be summarized as placing a radial artery. I'm now describing for severe preeclampsia. Placing a radial artery cannula, women with severe hypertension, small sized endotracheal tube and supraglottic devices to be kept ready. Administration of H2 receptor antagonist 30 to 60 minutes before induction of anesthesia. Denitrogenation for 3 minutes or 8 tidal vital capacity should be mandated in all the cases with FiO2 1.0 with tight fitting mask, face mask. Labetalol 10 mg bolus dose can be given between, if pressure is between 140, pressure is more than 140 by 90. We should continuously monitor the FHR during labetalol administration. Rapid sequence induction should be practiced with propofol 2 to 2.5 mg per kg body weight and scoline 1 to 1.5 mg per kg. Ketamine should be avoided as a induction agent. Sir, for maintenance of anesthesia, volatile halogenated agent with 40 to 50% oxygen should be given, and if at all nitrous is used, then 50-50 or 60-40 percentage can be used. After delivery, we can decrease the dose of halogenated agent, and we can consider giving opioid after that. We should avoid giving additional muscle relaxant. It should be supplemented only and only if it is absolutely required after the dose of schooling. At the end of surgery, neuromuscular blockage should be reversed with sugammadex, and before reversing, to blunt the effect of extubation response, labetalol can further be used, sir. So now coming on to post-op analgesia. Post-op analgesia is multimodal approach, and it comprises of paracetamol, NSAIDs, non-steroidal anti-inflammatory drugs, IV opioid. Non-steroidal anti-inflammatory drugs should not be used if we are suspecting any bleeding diastasis. IV opioids, continuous epidural infusion, transversus abdominis plain block, infiltration of local anesthesia around the bone. If hypertension persists more than 1 day post-operatively, NSAID should be replaced by alternative analgesics. Postpartum management, we should be watchful for pulmonary edema, sustained hypertension, stroke, venous thromboembolism, airway obstruction, and seizure. Magnesium sulfate should be continued until 24 hours of the last seizure, sir. Sir, finish.
Finished? Very good. It's a very detailed and well organized presentation. Congratulations first for that. But there are a few points which are missing in this answer. What is the reason for the pulmonary edema? You said pulmonary edema is very common and it can happen if the patient has already a chronic hypertension in which pregnancy, preeclampsia is superimposed. Apart from that, is there any other reason for the pulmonary edema, even in a non-hypertensive who becomes hypertensive for the first time, a preeclamptic patient? Is it always because of fluid overload or cardiac failure?
Vasodilation of the lung means lung vessels means pulmonary vessels can also lead to pulmonary edema, but
Vasodilatation, how it can produce, is mainly because of the capillary endothelial leaking. Okay, so the eclampsia is described as a entire body suffering from capillary leak all over the place. Okay, So even the pulmonary vasculature endothelium, they lose their tight junctions and become leaky, number one. And second, they lose proteins. If the heavy proteinuria, if it happens, they become hypoproteinemic. And that will make the hydrostatic pressure supersede the oncotic pressure of the blood. That is why they start losing that water into the interstitial spaces and alveoli. And that is how it is called non-cardiogenic pulmonary edema. So it is not always due to cardiac failure. And that is the reason why suddenly, even when the BP is only 130/80, well controlled, still they can develop a pulmonary edema. Okay, so that is the reason for the what is called the so-called non-cardiogenic pulmonary edema is very common, which you have to be very, very careful. And when you talk about fluids, you have to talk about what fluid to be selected, how to administer. The natural tendency for us will be to think of a colloid because patient is already hypoproteinemic. They are losing protein in the urine. So what we will think is it will be better to fill the vascular tree with a colloid rather than a crystalloid solution. And which is the colloid of choice?
Yes. Hydroxythiazide.
Huh?
Albumin, sir?
Human albumin is the best choice because all the other colloids, hydroxyethyl starch especially, is nowadays considered to produce a lot of renal complications. And you have to mention very much about watchful monitoring of the urine output, which is a very, very important indicator of the severity of the disease. Okay, so the patient has to have at least 0.5 ml per kg per hour of urine output. And what are the two important causes of mortality due to preeclampsia in the pregnant woman?
Coagulopathy, sir? Coagulopathy means?
Coagulopathy is happening only in
later stage
cases of HELLP syndrome, where there is a low platelet. But even otherwise, in a pre-eclamptic woman, even with a milder form, what are the causes of mortality? Because of this high blood pressure, they develop a hypertensive episode. Intracranial hemorrhage and renal failure are the two important causes of mortality in patients with preeclampsia and eclampsia. And you have to mention something about a preeclamptic turning into eclamptic also. Supposing a preeclamptic woman at the age of 34, gestational age of 34 or 36 throws a fit, what will you do? And how to manage that eclamptic attack? And what is the decision to be taken about delivering the baby and the placenta? Because the ultimate answer or the treatment for curing the preeclampsia or eclampsia is delivery of the fetus and the placenta. The placenta has to come out. Okay. So if supposing the lady throws a fit, how do you manage it during the seizure attack? And what decision has to be taken after the seizure is controlled? That point also has to be mentioned in your answer. So how do you manage that?
Sir, as soon as the patient is throwing seizure, left lateral means patient should be shifted on to left lateral position. And
why you want to shift her to left lateral position? That also you must explain.
Sir,
what are the advantages of this? It should always be left lateral or can it be right lateral also?
Left lateral position is preferred, sir, but they can be shifted to either of side, but left lateral is more preferred than right lateral.
Okay, why you want that first of all in this scenario?
So gravid uterus is there, so supine
that is always there in any woman. If it is hypotension, supine hypotensive syndrome, we always prefer to turn them to the left. But when they are throwing a fit and having a seizure, what is the reason for turning them to the lateral side?
So that, sir, if any to prevent aspiration means
aspiration. Very good. Airway must be clear and the aspiration should be prevented. Okay. So that is another reason, not only for removing the weight of the uterus from the IVC and the aorta. The main reason for turning them lateral when they are throwing a fit is to prevent aspiration. If they lie supine, they are definitely likely to aspirate because of the obstructed airway reflexes. And we must make sure that their airway is protected and injuries due to the biting of the tongue or lip is prevented by a bite block. And supplemental oxygen is given. That is the first and foremost airway management that you have to carry out when the patient is throwing a fit. Then what do you do? What is the next step?
Sir, instantaneously IV access should be taken so as to give magnesium sulfate, sir.
Okay. Magnesium sulfate. Suppose she is already on magnesium sulfate, what do you do? Supposing magnesium sulfate has not been started and suddenly she throws a fit, then what will you do?
Sir, if she is not on magnesium sulfate, I will go ahead with the loading dose of magnesium sulfate.
Very good. You have to give 4 grams to 4 to 6 grams IV bolus slowly within a period of 5 to 10 minutes. Here, usually we take 15 to 20 minutes to give the bolus dose. That is a normal recommendation. But when a patient is throwing a fit and has not already been started on magnesium sulfate, you have to make it a little more rapid and inject it within about 5 to 10 minutes. What precaution you will take when you are giving it a little more rapidly when the patient is throwing fit because they have not been started on magnesium sulfate? What monitoring should be established at the time?
Respiratory monitoring should be means, but though it takes time.
It's respiratory or cardiovascular monitoring?
Cardiovascular means.
They can get arrested. Okay, so you have to
yes,
monitor the heartbeat. So you have to put an ECG. ECG lead should be applied and ECG should be monitored if you are trying to give a rapid bolus of magnesium sulfate. Can you give them any other anti-epileptic like phenytoin, which we normally give, or benzodiazepines?
Benzodiazepines can
The
be
normal treatment for other people who are having epilepsy is benzodiazepine or phenytoin. So why not use them here?
Teratogenicity, but
they are only second line treatment in pregnancy. Okay, because they have a respiratory depressant effect on the fetus also. So we have to take care of the fetus. So that is the reason why these two drugs, which are commonly used as an anti-epileptic agent in normal epilepsy, we don't prefer them for the treatment of convulsions occurring during eclamptic attack in a pregnant woman. Okay, and so these points also you have to add in the answer for your this thing. And normally there are some dilemma stages where we go into a dilemma. For example, supposing a patient has got, as you said, a very severe degree of preeclampsia, but she has not had an eclamptic attack alone so far, but her blood pressure is 200 by 140, and she complains of headache and some visual disturbance. But her gestational period is only 32 weeks. What will you do?
Sir, I will first try to control the blood pressure.
Very good.
It means first line drug is labetalol, second line is hydralazine, or calcium channel blocker.
First answer for that is the patient should be admitted if she is attending as an outpatient. That is the first answer you have to say. She requires admission and close monitoring should be ensured. Then you go for control of blood pressure with intravenous medications, not just oral medication. Go for intravenous medication because she is already symptomatic. She is having headache, she is having visual disturbance. The time may not be far, she may throw a fit also. So our aim is to rapidly control her blood pressure by intravenous medications, right? If she responds well and good, supposing the BP comes down to 140, 80 after your intravenous treatment, what will you do?
Sir, for next 24 to 48 hours, she should be kept under with administration of corticosteroids. And if my institute has means fetal and tertiary level care, then I will keep that patient to my institute, or else I would like to refer that patient to institute which has an neonatal ICU along with maternal HDU. And
So you can refer it to a higher institution. But
Yes,
if you are working in a higher institution, what is the decision to be taken? Supposing you are working in a well established setup with all facilities, both for care of the mother as well as the fetus. Then at 32 weeks of gestation, a severely pre-eclamptic patient, well responding to intravenous medications, antihypertensives, what decision should be taken?
we will continue the
Allow the
pregnancy.
pregnancy to continue, or should you terminate and make the baby delivered?
Sir, we will allow the pregnancy to continue with continuous monitoring of the patient, sir.
Continuous monitoring of the fetus as well as
Fetus
the
and
mother.
patient. But,
Okay. So you have to do both monitoring of mother as well as the baby, right? Supposing she is not responding, she is still symptomatic, headache is persisting, BP is not coming down. There is only a marginal reduction from 220, 140, it has come to 210 by 130.
then expedite means delivery means should be done along with because we have to save we will try to save both of them with high risk for the fetus.
Priority goes to the mother.
Mother
Okay,
priority.
always priority of life is for the mother than the fetus. Okay? So if mother's life is in danger, that should be avoided first.
Yes.
Don't worry about the baby. Okay. If only you can salvage the baby without any risk to the mother's life, then only you should think of that possibility. Right? So if the patient is not responding to the treatment and continues to be symptomatic with headache and visual disturbance, then you must explain the risk involved in the continuation of the pregnancy to the mother and the relatives, and also make sure that the 32 weeks, even at 32 weeks, you can definitely save the baby if you have a good neonatal intensive care unit. Okay, so explain all these things, document the whole thing, get the consent from the mother as well as the relatives, and now the baby has to be delivered. Will you allow a normal induced labor and allow a normal vaginal delivery, or go for a C-section? That is the next dilemma.
We will
How
go
will you
for a
decide?
C-section. Go for a C-section, sir. Please.
Go for a C-section, 32 weeks. Yes, when the patient is symptomatic and if you induce labor, unless you have a very good epidural working to control the labor pain, you cannot risk allowing her to go for a normal vaginal delivery. So the stress itself is likely to convert a preeclampsia into an eclampsia. So it is rather safer to go for a cesarean section and deliver the baby if you have good neonatal intensive care facilities. Even at 32 weeks, we can deliver the child, and we can assess the weight of the child in the intrauterine. This thing itself is a USG. So with all those facilities, we can definitely allow a C-section to go on and control the thing, so that once the baby and placenta are delivered, we hope the blood pressure to settle down. But sometimes, as you said rightly, it may even prolong and extend even up to 72 hours post-delivery also. Some books say even up to 15 days or 1 month also they can have a eclamptic seizures. So we have to be very watchful in those patients and then take to control the blood pressure correctly. Okay. And another common question in the Viva they may ask you is, why you always insist that the blood pressure recorded after 20 weeks of gestation is considered as preeclampsia or hypertension, gestational hypertension?
Sir, the cytotrophoblast invasion in the spiral arteriole starts by 12 weeks, sir, and it finishes by 16 to 18 weeks of gestation, sir. So remodeling actually occurs after 20, around at the age of 20 weeks of gestation. So if that does not occur, then preeclampsia is.
So that is the reason for always the definition saying that it should be after 20 weeks of pregnancy, because that is the time the complete implantation. Because this pathophysiology of this disease is improper implantation of the placenta and ischemia of the placenta. These are the two main causes or pathologies which trigger the whole event, and an inflammatory response goes into the entire body system, and that is all the endothelial surfaces everywhere in the body, and they are all affected. So that is the reason why we always say it should happen after 20 weeks of gestation. If it is present even earlier than that, we call it as chronic hypertension, because nowadays, mothers get pregnant even at the age of 38 or 40 because of various reasons. Their working nature, the infertility problem, and patients going for artificial aided in pregnancies. So all these patients are likely to develop this problem. So they may already have an existing hypertension. That is why one of the classifications is chronic hypertension, wherein preeclampsia is superimposed on that. So earlier it was only because the girls were getting married very early and pregnancy was occurring around 20, 22 years of age. They develop preeclampsia without suffering from any chronic hypertension earlier. But because of late pregnancy nowadays, many women become hypertensive even before they become pregnant, and on such patients, the chances of getting a preeclamptic imposed on them is very high. So that is the reason why there have been different classifications going on. They have been modifying according to the changes that happen in the society. The women getting pregnant at the older age, they have included chronic hypertension with the superimposed preeclampsia also as one of the subdivisions of the types or the pregnancy induced or pregnancy associated with hypertension associated with pregnancy has been classified. That classification has been going on, being revised in according to the epidemiology and the population coming with hypertension during pregnancy. Okay, right. So that was a good presentation. I'll just there is some question here. What is the role of echosprin? They have tried that. Anyway, I'll just show a presentation which most of you would have seen.